It is a pleasure to kind of to moderate this session myself and introduce our panel members for this session on uh, remote healthcare, enabling access in remote healthcare, connected care. We have uh, our first panelist. I would request Dr. Arora to to step on the dais, please. He's an MBBS and MD in pediatrics from Delhi. He is a clinical research fellowship NPM program from University of Ontario, Canada. He has more than 20 publications in national and international journals to his credit, and also a textbook chapter in the program, in the clinical program that is published in his name. Secondly, I would like to call on stage Dr. Shailesh Jawar. Dr. Shailesh Jawar is the director, for Apex Hospitals and Critical Care Hopes. Critical Care Hopes is an organization which is bringing remote critical care to people nearer to their homes. Next, I would like to also welcome Mr. Rajendra Kuradi, who is the CEO and Research and Development Head for a company called R2 Healthcare, R2W Healthcare Solutions, which provides solutions which are there for remote healthcare. Thank you so much for joining. Dr. Shailesh, I would like to, you to take the first question in terms of, you have seen, you have been working with remote care and on-ground care for quite some time. What kind of changes that you have seen that was there during COVID and after COVID? You managed a lot of patients during COVID remotely as well. Is that a continuation that you are seeing, or is there something that still needs to change where remote critical care delivery is seen?
So I think we all evolved, I think, in COVID, whether by choice or by default, or whether it was in crisis. And I think evolution only happens when in crisis or by nature itself. I think so. So the digital acceptance of tele-ICU or telemedicine, if you think about it, was about 5% in 2019. At the peak of COVID, if you look at a population of 1.3 billion, it was 47%. So pre-COVID, the digital door was closed. So I think what COVID did was, the first thing is that human behavior, acceptance, and the digital door opened for the first time for the mass population that we serve. And that was very, very important. Secondly, I think today, Sir mentioned, and a few people also mentioned, we all know the data for telemedicine from India on the tips of our hands. 10 million, e-Sanjeevani, this, that, the other. If you look at any data points, before 2019, so ISRO launched the telemedicine project in 2001. No data existed till 2019. And in 2 years, we have data, we have numbers, we have everything. So this behavior change, this door opening did something very, very dramatic. And what I think the boost which telemedicine or tele-ICU will get is that now the knife hanging on the telemedicine's head, whether it works or doesn't work, that for once and all, it's been solved. It works, the data is there, the quality is there. Yes, it's a work in process. It will get better. Secondly, I always believe that I think we are a volume country, and it's a challenge, but it's an opportunity also. The kind of volume that we cater to and the kind of value that we deliver, if you look at data, if you look at price points, if you look at everything, it's phenomenal. I don't think so any other healthcare system can do that routinely day in, day out. With that volume, value, and when you add the decision-making process, command centers, we're talking about e-Sanjeevanis and everything, I think we'll see in 5 years the entire ecosystem of telehealthcare or healthcare probably go leaps and bounds. What happened in 2 years in COVID I think would have not happened in the 15 years or would have taken 2 decades. So the acceleration is completely immense, I think what COVID did. Secondly, I think whatever care we envisage now, I think as a consumer, as a provider, or as a government, we all talk about these words which have resonated today a few times. It has to be integrated, it has to be collaborative, it has to be innovative, and third is there has to be a digital or a technology layer which acts an enabler to deliver that care. So I think those are the few things that will really change how we deliver care in the post-pandemic era.
Right. Thank you so much, Dr. Sailesh. Dr. Rohit, critical care as specialty is kind of, if we say in the parlance of, healthcare, is quite new. Right? And that's why critical care specialists are, as we were mentioning, like any other super specialists, are quite low in numbers when it is concerned, not only across India, but across the world as such. We have multiple maternity centers, nursing homes, which are traditionally across all across the country, including urban areas, if you see. Do you see connected care as a solution to bridge this gap? Is it possible? How is it possible? What kind of solutions are required for these?
Yeah, okay. Thank you, Pankaj, for inviting me. I'm Dr. Rohit Arora. I'm a neonatologist at Cloud9 Hospital, Gurgaon. And I'm also spearheading the tele and ICU project, which we are doing in North India. Just to create a preamble to your question, Pankaj. So when we do surveys to figure out which city we should open an ICU, tele and ICU, like, so you have to have certain number of deliveries happening, and then accessibility to the healthcare should be not that good. If they are there, then we are not required, right? So based on that, that's how we plan to decide. So during our surveys, we get to learn a lot about different places. First of all, my learning has been that every city has got its own issues, right? They are on a planet of its own, totally different from the other adjoining city, and then totally different from the third city. So that's what we have learned. All cities have their own issues. Second, in all cities though, there are like 3 types of healthcare providers which we see. So Mr. Prasanna also mentioned the past and the present and the future. But I think the past is still there in terms of, as Pankaj was also mentioning, that a lot of population is still being catered to by non-registered medical professionals, right? We politely call them quacks or whatever, but they are still there and they serve a number of population. So it's not just we are concentrated in metros, but the real India, they are still being served by the quacks and the non-registered. Then the second hierarchy is the registered medical practitioner, which are trained graduates from modern medicine or Ayurveda and all. They generally have their own hospitals, which we found out that they open their own hospital to provide various specialty cares in there. And when they have problems, they tend to refer to either to the adjoining cities or, if they're lucky, a specialist hospital also in the town. And the third is the specialist hospital, if they are available. They are far and few in those cities, but some cities do have it. Exceptions are also there. For example, state of Punjab, we were happily surprised that they even have neonatologists and intensivists even in far-flung places. But in UP and Haryana so far, the outside peripheries, this is the strata which we found. So yes, there is huge dearths, and I'm not talking of intensivists and neonatologists, I'm just talking of specialists like surgeons, gynecologists and pediatricians. They are also very far and few. In fact, the latest data, the National Health Statistics, Rural Statistics, 2021 suggests that more than 70% CHCs lack specialists. So we have huge dearth of specialists in our country at this point. So yes, tele and ICU can work as a bridge in those places. So it will reduce the cost, morbidity, as well as mortality. So transport, especially in my field, neonatology, the fact that baby taken out from the cot to the incubator, downstairs into the ambulance, going through the road, reaching another facility, this itself changes the outcome and the whole of the life of the baby. So tele and ICU can bridge this gap by converting certain patients which could have been easily managed in those places and getting them managed through the tele facilities. So there are the patients which they easily manage, they are fine. The patient which for sure need support of higher center, they are also easy to figure out, right? Easy to transport. It is that in between chunk which can be managed, but because of lack of specialist care, they have to be transported, right? Not just the lack of the equipment, just the knowledge gap which is there, and it forms a major chunk, right? For example, a 34-weeker baby who's having respiratory distress, if you provide certain amount of basic care for 2-3 days, generally settles down. But if you transport them from one place to another, it's a huge hassle for the family, for the baby, and everybody else. And that bed, which could have been occupied by a sicker baby in a metro city, is now taken up by this baby who could have been managed there. So all these problems can be managed by tele and ICU services, which we are finding that we are trying to solve this.
Thank you so much. So my next question would be to Rajendra. So these are challenges that are faced when we are delivering clinical care to remote clinical care, critical care. What are the challenges from the technology side that you face while developing a platform or a technology which caters to critical care?
Yeah, thank you, Pankaj. So I represent a company called R2 Healthcare Solutions as a technology provider in tele-ICU care area. I think I'll touch upon few objectives of tele-ICU care or remote critical care and what are the challenges and the solution that we can. So one, as you mentioned, the tele-ICU care needs a 24/7 continuous information transfer. So that is very important. So because critical care is such that you cannot kind of wait for holidays or work days or nights. So we are continuous 24/7 care. So one of the basic challenge would be infrastructure issues in the hospital and the medical devices that we want to monitor and the patient informations. In this context, I think in the case of a new hospital, that is something that I work very closely with BBMP hospitals in Karnataka, where I work along with the hospital stakeholders to bring them on board in terms of implementing the technology, where we have designed the smart healthcare solutions and then work with the IT infrastructure providers to provide right network for each bed, for example, routers to each ICUs, and creating the space for command centers.
Thank you so much for that insightful thing, Rajendra. I'll come back to Dr. Rohit on the skill development part that is there, which Rajendra touched upon. Do you think this also as a way, remote critical care, remote NICU that you provide, somehow building up capacity in places where this kind of skill is not available? They might not be critical care specialists or intensivists or neonatologists, but can they be brought up to a particular skill level, which is, which aids them to either diagnose, understand whom to redirect, when to redirect, such kind of issues?
Yeah, no, absolutely. In fact, that's one of the major reasons tele-ICU or tele-ICU for that matter will work, that it will create standardization in the care, and we know research has shown standardization improves outcomes. So as I was saying, three kinds of patients: one easy to manage, one very difficult to manage, easy to find out what to do with them. Difficult part is the middle ones. So here comes the role of the technology, in the sense that you provide that much of care and bring out confidence in the spoke team, and the fact that you are there for the backup for troubleshooting, which gives them confidence to take care of that baby and not transfer them. So indeed, of course, standardization will change the outcomes, and we are in the process of collecting data, so it is already showing good results. In fact, one of the cities, we have brought out a 25-weeker, 700-gram baby without a ventilation. They wanted to publish it in the newspaper. We have to stop them. No, don't do it right now. So yeah, it is showing the results. Yeah.
Thank you so much, Dr. Saab. Now we have heard about how it is important, how it is aided, some of the challenges while creating the platform as well. One more problem that we have been, deliberating upon all of the panels and earlier also was the, affordability part of it and the way it is being made accessible. Dr. Shailesh, do you think that there are still, evolving business models, ways in which remote critical care can be delivered than the way it is being delivered as of now?
So I think the challenge is there is no right business model right now. So I will tell you what we think. We are also evolving continuously. Secondly, I think how you're delivering care, you have to design your business model to where you're delivering to the point of care. I think which healthcare has done, and we have discussed in the morning. If you look at the y-axis, there is an entire ecosystem in critical care. I think if you look at it, I'll just give you an example. One patient in a tier 2 town like Jaipur will probably cost about 40,000-50,000 rupees for an ICU patient. Okay. If he is in a remote location, we can treat them in 18,000 rupees. But if you look at the socio-economic data, ambulance traveling cost, which is around 35-40 rupees per kilometer, 3 days, 4 days loss of pay, disconnect from the community. Fourthly, we travel economically or mentally in India, we travel with 4 or 5 people going to the hospital, especially it's ICU. So if you look at the economic cost of this, and then I think there is a data about 41 or to 35% of patients die in the back of the ambulance, like Dr. Rohit was also saying. If you all collate it together, I don't think so affordability is the question if you understand, because there is enough money. We did a calculation. If a 40-year-old is referred rightly or treated locally, about 9 crore rupees he can contribute to the economy in his working life. Secondly, I think the other thing is that you're also contributing to the local economy. When you are trying to go and do a digital solution, you cannot import everything. You have to hire locally. You have to create an ecosystem locally. As you were saying, teaching programs locally. You have to become a part of the community if you have to be truly affordable. Once you become a part of the community, you're truly local, you understand the customer, you understand the ecosystem, I'm sure there is enough value that you can unlock there. Second thing I just want to point out is, it's very, very important sometimes is, I think this is what I have learned. We started initially with a Netflix-like subscription model, that you can subscribe to our services, and we thought it will work beautifully, it will be very low cost. We have fixed costs in the command center, and that will work everywhere. Obviously, it did not work everywhere. Then we went on a hybrid model, we'll do this, we'll do that. I think the most important thing is when you are trialing out different models, affordability is, yes, important, but what are you trying to solve? Actually, you're trying to solve the customer outcomes or the patient outcomes or solve the problem. You have to put a risk versus benefit, because if you are actually affordable but still not able to solve the bigger problem, which is outcome, then I don't think so the business model is true.
But how can technology be an enabler, frugal technology, to ensure that the business models that they're looking at and experimenting at can be much more effective? How can technology become more affordable to the business models that is being provided?
Yeah, thank you. So actually, just to extend the previous question, where I probably missed that point of device side of it. So this is also an opportunity for me to kind of push forward, like how we bring an affordable to that existing infrastructure. So as you said, like any hospitals would buy the medical devices from different vendors. So we cannot enforce them to buy a new device or a dedicated device or a standard devices to make sure that we can connect. So for that, we definitely have a solution. We brought in a vendor-neutral device integration platform and real-time monitoring platform to manage. So with that, we could able to tell the hospital that with the current infrastructure, we could able to bring in the solutions. Probably democratizing. See, this whole cost, right? not very limited to the hospital. End of the day, it will go to the person or a patient, I can say, and then he has to pay. So what I am kind of thinking is, we need to do a democratization of the entire tele-ICU services to reach these services at home. I think it is not like everybody need to get admitted to the ICUs. There are long-term, ill patients where still be in ICUs where they pay a lot of money. So, we can actually, create an intermediate centers, or can we manage them at home with the technology that we are providing, actually. So with that, I think some of our consultants are actually trying that way, where, some of these long-term critical patients are actually moved back to the home so that they can be monitored, and aged people, like, you cannot just put them into ICU always. So those are the aspects that we are looking at. The other one is, for example, leveraging the government initiatives and the CSR fund. So that is something that I did proactively, where I went to many multinational companies, identify the CSR opportunities, and connected to these hospitals in the tier 2, tier 3 cities, specifically some of these government hospitals, brought in this infrastructure or a financial assistance, and then brought in the technology, so that end of the day, the people who are actually getting benefited out of it.
Quick 30 seconds each, if I may ask a bonus question, please. Do you see a role of AI helping this cause in the future? I'll start with Rajendra.
Yeah, absolutely, actually.
30 seconds,
so when I keep discussing with the doctors, it's all about how a smart technology and advanced technology can translate that into a simple way of working for the doctors. So for example, alarm management, the indication, the information goes into their mobile. The background can be AI or whatever the technology you're talking about, but the information should be given to the intensivist at the right time at any place. So that is.
Thank you. Dr. Sailesh.
So I think most clinicians will agree. We already use AI. We used to call it the end of the bed test. That in COVID we used to do that end of the bed test sometimes, because you would probably see 50, 60, 70 patients sometimes in an hour. So yes, I think if you have limited resources, to align those resources with the capabilities of the provider. If I'm saying intensivist, so let's say there are 5,000 intensivists. So definitely the solution will be technology enabled by AI to align the limitations with the resources. That will be in true enabler.
Right, Dr. Arora, please, your views.
Yeah, I'm not sure at this point. I think we're jumping the gun. Let's have good quality internet services first in the peripheral areas. And we are rolling down 5G, but it's not more than -2G there.
Yeah.
So, yeah.
So thank you so much for that.
People from BAL are here. You can ask them actually.
So thank you so much. It was a very, very interesting discussion, very close to my heart as well.